of Surgical Oncology has always done a series of educational reviews about contemporary areas of growth and of interest to surgeons. There is no more greater interest right now and impact on cancer therapy than the revolutionary breakthrough of using these new immunotherapy agents, specifically the checkpoint inhibitors that break tolerance. I've been doing immunotherapy trials for 40 years. We gave lots of things to stimulate the immune system, thinking that it was just deficient and we had to boost up the immune competence, and we were wrong. And we now understand why our attempts to stimulate the immune system failed, because if the body is tolerant, it doesn't make a difference how much you try to immunize. You have to break tolerance and then allow the immune system to recognize cancer as a foreign invader and reject it just as it would a virus, a fungus, or a transplanted tissue. It's the same mechanism. So this is a revolutionary new concept to understand about immune tolerance, and in addition, to have the tools to break tolerance. And once that is done, the immune system is unmasked. It was blindfolded before, and it can begin to be a very important addition to our other oncology treatments. So this is actually, I would view, a revolution in cancer management as an additional way to treat patients, not as a substitute. We still need surgery. We still need standard targeted therapy and chemotherapy and radiation therapy. But one added benefit of immunotherapy, if you unblind the immune system so it can start to identify cancers as a foreign invader, and you give chemotherapy and targeted therapy at the same time, it breaks down the tumor, releases tumor antigen, which becomes an internal vaccine unique to the patient that helps boost and stimulate the immune system. So that's why you're seeing in advanced cancers right now even a more striking survival benefit when you add these checkpoint inhibitors plus a treatment of the primary tumor directly, such as targeted therapy and chemotherapy. And those strategies now will move from stage 4 cancers into the surgical arena. And that's why surgeons need to understand the value of this, how to incorporate it into their practice, and especially the concept of neoadjuvant therapy. Because we as surgeons have to understand when it's right for the patient, and in a multidisciplinary treatment plan, start to allow systemic therapy to be the first treatment, but be in the treatment arena so that at the proper time, the surgeon can take the tumor out. And that gives the advantage of knowing what's inside the tumor, because we found that sometimes these masses that we're measuring don't move. And by normal chemotherapy criteria, that would be no response. But in fact, with immunotherapy, you're creating a chronic inflammation and scarring. So unless we know what's inside the mass that we're measuring, we find sometimes that a tumor that didn't shrink, which would mean no response, actually had a pathological complete response, because when you take the tumor out, there's no tumor left. So a question that I'm commonly asked, because I give lectures about immunotherapy a lot around the world, the first thing I say is you have to take off your chemotherapy hat, because the rules of indications, monitoring response, and symptom management are very different for these checkpoint inhibitors than for the rules of engagement, monitoring, and symptom management with chemotherapy. So we have to understand that these checkpoint inhibitors are not treating cancer. That's fundamental. They treat the immune system so the immune system can treat the cancer. And because the immune responses are common to almost all cancers, these are fundamental principles that we've learned in some cancers that apply equally in other cancers as well. So we've learned that we can break tolerance, and that you can't just measure the masses and look for a major response with shrinkage of the tumor, because the masses might not shrink because they're replaced by chronic inflammation and scarring. So it's very important for cancer surgeons to remain up to date. This is a whole new field of cancer treatment. It has a new understanding of human immunology and a new understanding of how to manipulate the immune system. That's totally different than the way we treat cancers and understand cancer biology and cancer treatments. This has been so successful in a revolutionary way in the management of stage 4 patients. Patients who have actually failed 2 or 3 standard treatments get anti-PD-1 as a single agent, and their immune system can still respond. So what we've learned in stage 4 is the earlier you treat patients with stage 4, whose immune system are not compromised by prior chemotherapy or by larger tumor burdens, that the responses increase. So intuitively, you know, if you use immunotherapy with checkpoint inhibitors as first-line therapy for stage 4, that the results are even better than that when you move to cancer patients with stage 2 or 3, whose immune system is more intact and whose tumor burden is less.